part, we will go very high level in terms of what types of models are out there, what is the role of getting good data set to train your models to be able to make worthwhile predictions. But then very importantly, we will talk briefly about some practical experiences that we have had during this modeling journey, we call it. So during the COVID-19 pandemic, several groups have come in together in the United States to work collaboratively, and that's very important. We were not building off of our own models, so we were working collaboratively, validating models from others as well, to be able to get more of a wholesome prediction of the spread levels in the different parts of the country. So we'll talk about some of those practical experiences during COVID-19. And then before we go into the next part of policy making, we will very briefly cover the flavor of these epidemiological models, what they entail, what types of models are out there. We'll not go into the math of it. We will just talk about the basic categories of models that are out there. Now, this first part will motivate the second part of the talk, which is more on the research side of things. So we will talk about how these types of models can impact policymaking decisions. And we'll talk about some machine learning based models, which can tell us what are the key factors that are affecting the number of infection and death counts, specifically in the United States and even worldwide. We'll talk about lockdown policymaking. So how do we even come up with a lockdown policy? What should be the length of the lockdown? When to impose the lockdown, right? So these are very qualitative policies that we generally take right now, looking at the infection numbers and all of that. So what we do is we actually run computer simulations and we run models, new algorithms, which can do lockdowns in a dynamic fashion. We'll talk about the flavor of what that would be. Dynamic vaccine allocation is another problem that we will briefly check out, where during a pandemic, so this is very different from the flu shots that we generally take every year, right? So we are talking about vaccination amid pandemics, which means that there are so many people infected. There are so many asymptomatic cases out there also. In a dynamic scenario like that, how do you do proper vaccine allocation? And this has been a problem worldwide, that we do not have enough vaccines to be given out, which makes the vaccine allocation problem very important. Where to give the vaccines when? How can we prioritize this type of vaccine allocation, right? So we'll briefly talk about that. Then we will go into social distancing. So of course, for social distancing, we created a mobile app in one of our published papers. So we will very briefly cover what kind of models can go into social distancing related policies. Then we will kind of taper into hospital capacity simulation. So what is the hospital capacity simulations? The whole goal of these models and for lockdown policies and all of that was to ensure that the United States are staying healthy in terms of its healthcare resources. So we did not want our healthcare resources to be overrun by the sheer number of infected population, right? So that's the reason why hospital capacity simulation becomes important. A lot of that work is currently, I'm still involved in that process. So we are working with the Virginia Commonwealth University Medical Center for hospital planning and logistics. How many extra beds and ventilators to allocate, looking at what is going to happen in the next month in terms of the spread models, right? So hospital capacity simulation. And then finally, we will finish it off with some public perception on COVID-related policies. Now, that's also a very important topic, because no matter how good your models are, a lot of this has to do with human behavior, right? So whenever we talk about policy making, social distancing activities, lockdown activities, and all of that, you cannot impose them strictly unless you have modeled the human behavior in a proper way. And that is something we realized during the course of our modeling activities. So that's the reason why we would take a slightly different route in that last topic to talk about how can we even sense public perception in real time. Okay, so the second part of the talk will be primarily on the policymaking aspects and more on the research side of things, while the first part is going to be a basic overview of epidemiology and some of our practical experiences going through this process. So with that, let's get started. So why do we even need these types of infectious disease models? So again, there are plenty of groups who have worked on these types of models in the past year. It gives us an insight into the mechanisms, right? How the disease is spreading with time. Also, very important is it can link individual level clinical knowledge to the population scale dynamics. Okay, so what is an individual level clinical knowledge? How long does it take for an infected person to recover? How long does it take for an exposed person, somebody exposed to the infection, to start developing the symptoms, right? So these are individual level clinical knowledge. And then these parameters can then be actually put together into large scale population dynamics level models, right? So that's the primary goal of these types of modeling activities, be able to use individual level clinical knowledge and be able to then project it over population scale dynamics. It also helps us in focused thinking. So whenever somebody is proposing a model, it's very important to talk about the assumptions. Every model is wrong to some extent because it has to make some simplifying assumptions. There is no model that is out there right now which considers all the different complexities involved in this activity, right, in infection spread. More importantly, the human factor, right, the human behavior factor. So proper articulation of assumptions is very important for these modeling activities. It helps us derive new insights and hypotheses. It helps us in thought experiments and what if kind of questions. So once you have a simulation in place for which has been trained based on infection data sets and other factors, you can now use it to predict the peak in the future and all, right? And based on that, you can actually tailor a lot of your COVID-19 related policies as well. So what if types of questions can actually be used, can actually be answered based on these types of modeling and simulation studies. It also establishes the relative importance of different processes and parameters. So I'll talk briefly about that relative importance part when we go into the hospital simulation aspect of this talk. What it does is it allows you to focus the research and management effort. Okay, so even from a management perspective, when you're looking at hospital administration, there are different components over there. It's a complex setup over there, and which ones to prioritize and when, right? So those types of questions you can answer. Now, this was a slide taken from Hesterbeek and Roberts back in '95. You'll see that the absence of predicting future trends. So these models are highly sensitive, okay? And it's very easy to go wrong with your modeling predictions, okay? So in a scenario like this, parameter values that you actually sense out of fitting with the actual data sets, they have high levels of uncertainty involved, okay? So that's why qualitative predictions are much easier to do in these types of scenarios than quantitative predictions. Like the peak is going to happen 1 month after and all, right? So that type of quantitative prediction is very, very difficult to make considering the complexities of these types of models, okay? So what is the role of data in this whole activity? So unless the data set is clean and readily available, all models will fall apart, okay? So the data will give you real patterns and it helps us to solve real problems like policymaking for COVID. What are the challenges? It's very difficult to get good data sets. Now the US has actually, once they realized how much is the impact of COVID-19 in the country, very authentic data dashboards have been set up all across the country. And there has been a lot of effort, funding put in proper data collection so that the data is as clean as possible and gets set up as quickly as possible, right? So if somebody is infected today, there's no point counting that 5 days after because the models will be completely wrong in considering those types of numbers over there, right? So having good data sets and timely data sets is very important. The real world is messy, right? So of course, these data sets are very messy in the sense there's a lot of missing data. Many people who have been infected doesn't come back to report when they have recovered or whether they had to be hospitalized or not, right? So many deaths have gone unnoticed. Deaths due to COVID have gone unnoticed because they have not been tested for COVID in the first place. So testing, the level of testing plays a very important role in making these data sets clean as well. right? So the real world is really messy, and the models has to cope up with these types of uncertainties. In the second part, where we will talk about dynamic policy making, that's the whole idea there, that most of these parameters are essentially very noisy. They have a lot of uncertainty. And in scenarios like that, how can you come up with a dynamic policy making, right? So that's what we will cover in the later part. Now, statistical models, statistical methods, it's a completely non-linear process. So you cannot say 5 people are eligible to get infected. It's not a linear relationship that if you come in contact with somebody, all 5 will get the disease, will get the infection, right? So there is always a chance, a probability involved in scenarios like this, and there is non-linearity involved as well. So it's not a linear process. So statistical methods, if you use those in these types of non-linear models, they can become very, very complicated, and they may not be able to spit out the right types of results. Now, there is another set of people who are working on pure theory for epidemiological models. They are also useful in giving us qualitative understanding in terms of understanding the concepts, developing methods, and integrating ideas, right? However, you'll have to go out to the practical field, practical playing ground, to be able to make proper policy level decisions. Okay? So overall, for the epidemic models landscape, you need only a few good theorists, brilliant theorists, let's say, but many strong applied models. Okay, so in this practical application that I talked about, so we at Virginia Commonwealth University, we have been working with most of the states of the United States and several academic medical centers around the country to come up with modeling consensus. So we were evaluating different models that are out there in the country. We were creating our own models as well and trying to come up with a consensus set of results that when the peaks are being predicted in each of these different zones. Okay, so we reviewed different models and we worked with the state as well in this activity. So we worked with the Virginia Department of Emergency Management, and 3 models in the country came up to be the leading ones compared to many of the other ones, right? So these 3 were University of Virginia Biocomplexity Institute. They had an epidemic spread model. UPenn, University of Pennsylvania Medicine, they had another epidemic spread model. And then finally, University of Washington, IHME, Institute of Health Metrics Evaluation, they came up with a statistical model, right? So these were the 3 primary models that came out to be the leading spread models in the country over this past year. Okay, and as I said, we have been evaluating several of these models during this process. So these models, they were updated several times a week. So with real-time data being coming in, these models were updated several times a week. Initial data was biased because of the lack of testing. So you'll have to understand that the infection counts that we use in terms of training our models, that's a biased number if there is not enough testing happening, right? And in the United States, just like in many other countries, the level of testing, the amount of testing towards the beginning was actually quite low, right? So which made a lot of these initial data biased and made the model predictions really go haywire, okay? And documentation for some models were better than the others. So when several of these medical centers are working together to make predictions, because we at Virginia in Richmond, we cannot just make a prediction for the Richmond zone, because there are these other neighboring zones that also plays a role in spreading infection into the Richmond zone, right? So in a scenario like that, you cannot just have single isolated models for specific zones, right? So documentation of models that are being used in these other zones also becomes important, because some of those parameters actually feed into the current models that we are producing for ours. Okay. So moving forward, then what is a good model? So model accuracy is only known after the fact. So if you're making epidemic spread models, you will only know how accurate is your model only after that period has passed, whether the peak has been reached or not. Models has to behave in explainable ways, because policy changes, if you were to make a policy change that, okay, it's time to take off the lockdown, right? You would expect the effects to follow the motivation for doing that. right? So you would want the infection count to saturate or to stay stable after the lockdown has been lifted up, right? So that becomes important. So the model predictions has to be explainable, and the magnitude of response is generally calibrated based on these real-time data sets that we use. Resource constraints are real, and there is an asymmetric risk with modeling COVID. Okay, now this is very important. Modeling of COVID is just not another modeling activity. Okay, this has got serious health concerns and concerns in the public domain. So, for example, if we predicted for a hospital capacity simulation, if we predicted too many ICU beds and ventilator requirements, that amount to high costs, right? So if the model is off, it's making a prediction of a much larger requirement of resources. We are looking at high costs in scenarios like that. But if the model is just doing the other way around, it's making predictions of too few ICU beds and ventilators, then we are losing lives, right? The hospital capacity will be overloaded and we may be losing lives. So the consequences of going wrong with these types of models is really dark, right? In a scenario like that. And that's the reason why the assumptions and biases should be reflecting this concern. So in this modeling activity, when we were evaluating all these models and all, we would never give out a single value for the peak. So you will always be looking at best case, average case, worst case scenarios. You'll be looking at blankets, because during about a month's time, you have to give for the model fluctuations and all of that. Okay, so with that, let's talk about the existing models that are out there, statistical models versus system dynamic models. So these were the primary two that have been used in the United States, at least, for during the past year. Statistical models are mostly projections based on curves and uses curve fitting with historic data, includes other factors like controls and policy responses. The University of Washington model, IHME, is of this type. Systems dynamics models use differential equations or simulation-based studies, assumes an exponential growth in the number of infected, and it estimates the rate of spread and uses that parameter in making modeling decisions. So the University of Virginia and UPenn's CHIME models fall into this category. Now, how do you do a modeling evaluation of these three types of models? In terms of a degree of threat, if you're looking at the degree of threat, or the vulnerability of a zone, let's say, both system dynamics and statistical models do not perform that well. They're in the yellow zone. But surveillance, actual surveillance, where you're actually recording the number of infections, you're doing contact tracing and all, that plays a much better role in understanding the degree of threat and the amount of spread. The rate of spread, if you're trying to identify the rate of spread, over there, systems dynamics models work a lot better than the statistical models. If you're looking at the extent of spread, how many people will get infected in this zone, right? Statistical models have not done so well in that scenario. Systems dynamics models are kind of okay. Timing of the peak, when will the peak happen, the maximum number of infections happen? Both systems dynamics and statistical models behave similarly for this specific question. Both of them are not very good at it, somewhat suitable, but that's all that we have at our disposal to go with. And of course, the severity as well, the severity level of the infection, even for that one, both system dynamics and statistical models do not work very well. Okay. So just a little bit on what exactly are these models. So this is something you all may have heard again and again over the past year. So UPenn's CHIME uses a susceptible infected recovered model. It's a very simple model. You consider a population which is susceptible, right? Everybody is susceptible to the disease, right? And then when you come in contact with somebody who is infected, that's when you get exposed to the disease and you start developing symptoms. And after a certain point of time, people recover, or some people may have to be hospitalized and things like that, right? So you divide up this model into different compartments: susceptible compartment, infected compartment, recovered compartment. Using these types of models, the Yupen-Chaim model, and of course the other models too, you can now compute very easily the number of hospital beds and ICU beds that are needed at specific points of time. So if you make a model prediction for the next 1 month, how many infections are we going to be looking at, you can now go back to the hospital authority and then try to allocate so many extra ICU beds and so many extra ventilators for that specific medical center, right? So generally that is used as fixed ratios. What fixed ratios would mean is that, let's say about 10% of the people who are infected may need to be hospitalized. So you basically use a fixed ratio of that. So your model predicts how many people may be infected in the next 1 month or so. And then you use fixed ratios to figure out how many beds and ventilators will be needed. Okay. And then these types of models uses the R0 value. R0, what it actually means is, for any single infected person, how many other people can that person infect in a day's time, right? So that's a ballpark estimate. This Yupen-Chaim model is generally works well towards the beginning, early and middle phase of the pandemic, right? However, it's a very simple model, very quick to run and all. How do you bring in policies in this type of a model is an outstanding question. For example, we'll talk about social distancing right here. So how do you bring social distancing in a model? Now, the Chaim model, Yupen-Chaim, just uses social distancing as saying reduce the number of contacts. So basically reduce the R0 value, if you think about it. So if you do that, you are going to see the red curve right here. It reduces, it really pushes the curve to the future a little bit and reduces the amplitude of the curve as well. However, social distancing can also be modeled as a certain segment of the population is no longer susceptible, right? So basically you're saying that if this section is doing social distancing, I will take out these set of people out from my list of susceptible people that can get infected. If you do something like that, the green curve would mean that the peak stays exactly at the same place. The peak is not pushed forward. Okay, the amplitude has actually gone down with this type of social distancing. And the blue curve over here shows you the scenario where no social distancing is happening. So this is the normal spread for that specific zone. However, so the point here is the same policy of social distancing. How you implement it inside your model plays a role in making these predictions, because you will see that the red curve and the green curve, they are predicting the peaks, the peak infections at different points of time altogether, right? In some scenarios, we have seen that even these three leading models that we talked about, the peak predictions basically were differing by about a month or so, right? And that's the level of uncertainty that is there in these parameters. Okay? So moving forward, UVA, the University of Virginia, uses something that they call the PATSIM model. This is also a variant of this susceptible, infected, recovered type of model that we talked about. Very importantly, they bring in travel data into their model. And when we go into the research side of things, you'll see how travel data plays a huge role in making many of these policy decisions. So they bring in specific travel data between the zones and then integrates it with the overall SIR model. This team has been working on infectious disease models for decades right now. Many of their models have already been calibrated based on actual flu spread in the US and all. They have used county level data to have better granularity of the models and then integrate the different counties together into a larger scale simulation that way. Okay, they've used Monte Carlo simulation with particle filtering approaches over here to be able to fit the parameters and understand the R0 values and whatnot. Slowing versus pausing growth. So for social distancing, they had two types of implementations. So social distancing is going to be slowing the growth, right? But doesn't fully stop it. So basically you're reducing the value of the R0 to some extent. Social distancing can pause growth. Okay, so for different fractions, different sections of the people, basically there's not going to be any spread. Generally, these susceptible, infected, recovered types of models, they consider a homogeneous population. So everybody has got equal likelihood of getting infected, right? The pausing growth aspect would mean that we are not letting all of the people have the same chance of getting infected. Okay, so those are some of the details of their model. University of Washington's IHME model. This is a statistical model based on curve fitting. They can actually also give you estimates of the hospitalization rates and the utilization of ICU beds and ventilators needed and all. This is not an SIR or SEIR type of model. It's a statistical curve fitting model that they use. So it's very different from the first two types of models that we just talked about. And these models are likely biased, the IHME model. So the model results are not stable. We have seen that the difference between the current and, so if you run the IHME model in the month of June versus in the month of July, their predictions basically may differ by about 25%. So the model predictions are not robust that way. Okay, because also of the lack of testing, many COVID-19 deaths may not be confirmed. So the IHME model works out of the death counts. So it's not looking at the infected numbers as much. It is looking at the number of deaths, and based on that, it is doing a curve fitting to figure out how many people might be infected or not. Okay, so if the number of deaths is not properly reported for COVID-19, these types of models do not work so well because there is a bias in the data set. So with the IHME model, these types of statistical models, policy level interventions are very hard to implement. So the key takeaway from these practical models that are out there and in the United States when we have been working with all of these models was the UPenn-Chime model pushes the peak too far because of how they use social distancing. So basically, if you're making a prediction of when will the peak happen using the Chime model, we have seen that their prediction says that the peak is too far away, but actually the peak is coming much earlier. Okay, IHME may have a peak too early on the other side, right? So even that's a problem. It is predicting that the peak is happening too early, so you're allocating resources, too many resources right at the beginning. UVA and IHME, both of these models get better as and when more data set is available. Dearth of initial testing can bias all of these models. If you do not have initial enough testing data, all the models will fall apart. And many of the parameters towards the beginning were being used from China, the R0 values and all of that, which may not be as relevant as a place like United States or even Dominican Republic and all, right? So every country has got their human behavior piece involved, and their R0s can actually vary a lot that way. Chime is best used as a decision support system. So for hospital level utilization predictions, Chime has been used a lot. And generally, and that's the reason why when we were doing these modeling studies, you do not just rely on a single model, right? So we always use the 3 models because these will give us an idea of the best case, worst case, and average case scenarios. And all 3 has to be brought in to be able to make policy level decisions. Okay, so with that, we'll very briefly touch upon what is SIR and SEIR models and all that. So it's essentially a compartmental model. People can be susceptible to an infection. They can then get exposed after coming in contact with somebody who is infected. The exposed people can transition over to infected category, which means that they are now developing symptoms. And after a certain point of time, they may recover or may pass away as well. Okay, so this is the very basic epidemiological model. Now we can bring in rate parameters over there. I'm not going to spend much time on some of these symbols. So you can bring in rate parameters. You can write a differential equation to solve these parameters. However, the SEIR models can actually be extended in many different scenarios. For example, if the specific pandemic or specific epidemic, let's say, does not all of them may need the recovered compartment. If you do not have data on how many people are recovering, reliable data on how many people are recovering, you don't want that compartment. You can just keep yourself to an SEI model, susceptible, exposed, and infected. And then if you're saying that the recovered can actually get reinfected, which is something we are seeing for COVID-19, we don't know very well what is the rate of reinfection, right? How many people who get recovered from COVID has got a probability of getting reinfected again. And what is that probability? What is the time delay? How long will they be immune? So many of these factors come in to be able to design a SIRS kind of a model where the recovered can actually go back to the susceptible compartment and get reinfected again. Sometimes, again, if your recovery data is not very good, do not go into the R compartment. You can just keep yourself to susceptible, infected, and back to susceptible again. In other scenarios, people have shown that there can be other compartments that you can add as well. Leptospirosis, for example, has got a chronic shedding state, like what you see over here. So you don't just have to keep yourself to the SIR model and all of that. There have also been efforts where people brought in birth and death rates. So for a specific population, there are new births happening, new deaths happening every day, right? So in a situation like that, can you factor that in your models to be able to truly understand how many people are out there in that zone and are have got the chances of getting infected around, right? So there are different modeling variations like this. R naught that we talk about, it's a very important quantity, because if your R naught value is called the basic reproductive number, of course, if your R naught is less than or equal to 1, the disease dies out, right? After a certain point of time, it will die out. R naught greater than 1, that's when we have this pandemic, right, for COVID-19. And whenever your R naught is greater than 1, you may do modeling for outbreak dynamics. What is the probability of it fading out? What is the growth rate of this epidemic and all? And you can also do disease control strategies like policy making. How many vaccines, how many people to be vaccinated? What is herd immunity and things like that? How do you compute R naught? There are methods of doing that, so let's not worry about that part. So this effect, there is also this concept of effective reproduction number. So R naught is generally a fixed quantity for a disease, but then different zones will have different values of R effective. And that's very important when you're trying to figure out the level of herd immunity for a specific zone, because the number of susceptible in different zones as a percentage of the total number of people in that zone keeps changing, right? So that's where your R effective becomes very important. As you will see, if your R effective is much greater than 1, you have a very high number of infected, the green curve, but it dies down very quickly because you have infected too many people too quickly already, and not many people to be infected newly, right? If your R effective is less than 1, you would see a smaller peak like this, and it will take longer to die down. Okay, so what is herd immunity, of course? So for achieving herd immunity, you're saying, I need to reduce the number of people who are susceptible. Okay, and then you can do some simple math to say that, okay, if my R naught is greater than 1, which is what is happening for COVID, I want to keep my R effective to be less than 1. We have seen that if the R effective is less than 1, the pandemic, infections will die away sooner or later. Right? So in a situation like that, your goal is to reduce the number of susceptible people. Okay, and reducing the number of susceptible people can obviously mean that I will try to vaccinate so many people. Right? So now you can simply do some very simple calculations, and this will tell you that 1 minus 1 over R naught, number of people, fraction of people. This is the fraction of people that I need to vaccinate in order to make my R effective less than 1 and for the epidemic to die down. Okay, so that's how people calculate ballpark figures of herd immunity. So R naught is a very important parameter, but there are other pandemic-related parameters as well. It gives you the probability of successful invasion, gives you rate of epidemic growth, when the peak will happen. So it is used in all of these aspects. It can give you the critical vaccination threshold, and it can also give you the threshold values for other control measures. So we do use these fitted R naught values, the R effective values, in the policy making set of activities that we will talk about next. One last piece for the first introductory part is that when you're designing a model, SIR is a very simple model, differential equation based model, right? So that's called a deterministic model. We also have more complicated and more accurate stochastic models over there, discrete time versus continuous time versus models, so discrete continuous state variables, random mixing, structured population. These are all important aspects. You cannot just say that every person has got an equal chance of getting infected. People are working in different zones, in different community structures, right? So can you bring out those community structures in your model? Is it homogeneous versus heterogeneous? Is everybody equally likely to get infected or not? We already know that's not the case, because some people, based on our genetic makeup, will react differently to the exposure to an infection. Okay, what's needed to build the model in terms of data needs? So we measured the latent period, the infectious period, immunity, how long will your immunity be after an infection, population data, population dynamics and all, birth and death rates, number of people moving in and out of a zone, rate of contact with other population groups. All of these factors are considered in building these models. And in order to validate, you're looking at the time series data. You're also looking at seroprevalence and seroincidence. So individuals' history and based on the antibodies that they have grown. So you're making those types of tests as well to be able to validate many of these models. Okay, so I will skip through this very quickly. There is also this contact tracing graphs that gets used. We at VCU Medical Center have been actually having our own contact tracing graph in the university campus. The state of Virginia was maintaining their own contact tracing graph at the state level as well. And the federal government was actually looking at contact tracing graphs at the country level as well. So these become important as well when you're generating these types of models. So with that, so let's go into some of the interesting pieces on the policy making aspects. So the first things that we did here was, can we identify the key factors affecting COVID-19 infection and death numbers? Okay, so we looked into a very comprehensive data set. We looked into the demographic, economic, epidemiological, ethnic, and health indicators for across the 50 states of the US. And we saw that we also saw airport traffic, homeless, number of homeless people in a specific zone. So we looked into some of these parameters as well. And we were looking at, we were using standard machine learning based models to be able to study the impact of these parameters into the COVID-19 infection and death counts. Okay, use multiple linear regression strategies for doing this. Okay, so this is a sample result that we got. So you'll see here that the peak death numbers. So P death is the highest number of death count at a specific time. That and airport traffic. These come out to be the most important factors affecting the infection and death rates. So the blue curve here is the infected numbers. The purple, the red curve here is the death numbers, and the number of pre-lockdown death numbers. So basically, for this this specific example, we divided up the data set as the pre-lockdown level and the post-lockdown level, right? And based on that division, we were considering for each of these parameters how they were affecting the post-lockdown infection and death counts and all. So air traffic became important, testing rates became important, PD is the population density, that was important, and then high age was also an important factor towards predicting these infection death counts. When you do a principal component analysis of this problem, it will, in the US, it will show you different clusters of states. So we got two clusters, group 1 and group 2. Group 1 is the red one, group 2 is the brown one over here. You'll see group 1 states are the ones that showed high early peaks in the United States. So New York, New Jersey, Massachusetts, Connecticut, and Rhode Island. These were the states showing very early peaks. Okay, group 2 states, they were showing steady infection counts towards the beginning, but they had a very strong second wave. So these are your Texas, Washington, California, Georgia, Arkansas. So these states are these purple ones, the highly affected group 2 ones, and they were showing they fell in a different cluster. So these types of data-driven analysis now make sense because these results are kind of validated results because that's what we saw in the United States. Now these group 1 states, if you check out what factors affect the infection numbers in these group 1 states, you'll see that road airport mobility, that plays a very high role, leading to high infections. And then we saw elderly people were more vulnerable there. For the group 2 cases, where we had a high second wave, high population density and testing numbers came out to be the most important features. Airport activity, so people coming from outside and all, that played a lesser role for the group 2 states. So this is why this type of statistical machine learning analysis can actually be very useful in designing policies, because when you're going into policies, these are the set of variables that we need to use to be able to design new types of policies. So moving forward, so some key findings that we saw: population density, testing rates, and airport traffic. These are the 3 key factors towards predicting the number of infection and mortality. High age group, generally 60 plus, is more vulnerable when you're looking at the death rates in different states in the US. The PCA plot shows early epicenters, so I can do a data-driven analysis to show which zones or states will form high first wave, and then the other cluster, we can actually segregate other places which may actually show high second wave, but not such a high first wave, okay? Now, if you divide up the data between pre-lockdown and post-lockdown, basically we saw that post-lockdown numbers are most influenced by pre-lockdown infected and death numbers, followed by population density and airport activity. Now, what do we mean by that? So if you divide up the data set pre and post-lockdown, it is basically telling us that if you're trying to create a lockdown policy of how long your lockdown should be and when to impose the lockdown, these are the 2 decisions we have to make, right? When and how long. You should be looking at the infection and death numbers, of course, but also the population density and the airport activity in that specific zone, okay? So these are the most important factors. And we have regression models, so it tells us what weight to give to each of these factors to calculate your duration of lockdown at a specific place and all. We saw the healthcare index. So United States has got a healthcare index which tells you how good the healthcare resources are in that specific state, right? So healthcare index did not play a role in the overall death count. So that means that many of the deaths did not happen. Most of the deaths did not happen because the healthcare system could not manage so many patients around. Okay, the race did not play a role in infection and mortality. So this was not a statistically significant parameter. We also saw that when lockdown was imposed, it took about 3 weeks for the infections to start declining. Okay, that gives you an idea of how many people are asymptomatic in that zone, that even after imposition of lockdown, it took about 3 weeks for the infections to start falling quite a bit. Okay, another important takeaway: mobility versus distance. So we actually looked into traffic traces inside New York City, and that told us that what is more important is not 2 zones, how close they are to each other in terms of geographical distance. What is more important is how many trips are made between the zones. Okay, that's a more important predictor than how close they are geographically. Okay, so with that, let's jump into the next interesting part. So dynamic lockdown policies due to infection spread. So what is this? This is more futuristic, right? So we did not implement dynamic lockdown policies. These are part of the policy making decisions. This is more on the research side of things. So looking at the problems of lockdown timing, when to impose lockdown, how long should our lockdown levels be, and all that. So we try to create a computer algorithm that can automatically match what is happening in the real world in terms of how the infections are changing. And based on that, can we automatically change the lockdown levels? So we say that, okay, zone 1, do a 5-day lockdown. Zone 2, do a 10-day lockdown. Okay, can we automatically make these decisions depending on the infection numbers and how they are changing? So that was the goal of this piece of work. So we created intelligent algorithms to make our lockdowns dynamic so that they can adapt automatically to the infection counts. We also considered hospitalization rates, right? Because the whole idea of lockdown was to ensure that the number of hospitalizations is not too high to overcome the healthcare system. So with that goal in mind, we were looking at this as a machine learning problem. So we use reinforcement learning to solve this problem. And we also considered user mobility levels. So just a pictorial view, of course, we are still running an SIRD model because this is futuristic, right? So we are running a simulation to basically say how the infections are gonna happen in a specific place, right? So we were looking at New York City with its 5 different boroughs and all of that. Now we have a reinforcement learning model over here and an infection rate SEIR. So what this is doing is the reinforcement learning model, that's where the intelligent algorithm was coded in, which was basically looking at in real time how each zone's infection counts are changing And based on that, it is making a decision what should be the lockdown level of that zone in that specific time period. Okay, so some of the details, agent-based simulation was used, reinforcement learning was used to do this. We have a way of calculating the reward function over here. And then you have to use a queuing model, because we were doing this to ensure that the hospitalization resources are not overcome, right? So they are kept at a certain level. So you use queuing theory to figure out how many people may be waiting to get into a hospital. And also some of those details has to be coded in there. It was all done in Python, and we used some clustering with KL divergence and whatnot. So let's not worry about that. So what we saw was real traffic traces from NYC. These are the mobility traces that we used, and this is the actual migration look from the simulation. Okay, so you can see that the simulation was matching the real traffic traces that we used from New York City. Okay, over here we are trying to show that how the reinforcement learning, how the lockdown levels work. So for example, in the first curve over here, the black curve is the actual infection curve. Now, if you change the velocity level of people, now this is just an abstraction, by the way. So velocity level, you mean that I'm letting people move, let's say, over a larger radius. So you're basically saying that you cannot just go beyond a certain radius because we have lockdown in place and all, right? So that's the lockdown policy that we are talking about. So if you increase that radius, your chances of infection spread is higher. So this, look at this brown curve over here. So if it is 20 times the lowest radius, so we divide the lockdown levels as to how far you can move during a lockdown and all. And based on that level of how far you can move, the number of infections cannot be controlled. So this red curve is actually full lockdown, nobody's moving as much. And then as you keep making it more and more lenient, you're going to see more and more infections, right? So that was the goal of this simulation. We also saw, so in this first curve over here, that change in the mean infected and death rates based on contact indices. So essentially, as you keep increasing the radius of the lockdown levels, the number of infections and deaths go on increasing, right? So that's what we are seeing over here in this first curve. If you keep increasing the radius of the lockdown, more and more people will get infected and maybe die. You know? And there are some correlations that we showed that what actually happened in Manhattan versus what our simulations were predicting in terms of hospital capacity use, in terms of infected death counts. The only place, we were looking at 5 different boroughs of New York City, so we got very good matches for Bronx, Queens, Brooklyn, and Staten Island. Only place where we did not match the numbers well was Manhattan. And the reason for that is traffic into Manhattan is much higher than any of these other boroughs, right? So that's the reason why even with real mobility traces, the simulation could not predict very well the number of people who might be coming into the Manhattan area and be responsible for the spread of infection over there. Okay, but apart from that, apart from very busy zones like Manhattan, this type of dynamic model could work quite well. So I'll skip this probability of Q and all. Very briefly talk about dynamic vaccination levels. So what are we doing over here? We are talking about how many vaccines to allocate to specific zones. Okay, so that's our goal over here during a pandemic. So what we have created here is a time varying algorithm. It's a time varying strategy. Basically, we are saying that, okay, I have a bunch of 1,000 vaccines right now in month 1. I want to distribute it to the different zones, looking at the infection numbers, right? So after I have done the distribution, I got another batch of new 1,000 vaccines in the second month. How do I distribute those vaccines, right, in these ones? So that's why it has to be a time varying case, because the vaccines are coming into the federal government in different batches. And the goal is, how do you divide up the vaccines amongst the different states in the US? And then once the states receives their quota, they're trying to figure out how to distribute it to the different zones and all. For this also, we created a dynamic algorithm based on optimization and all. But what is very important is we had to consider uncertainty in immunity levels. So you'll see this bullet point right here. Now that's very important. Now we say Pfizer's vaccine is 95% effective, Moderna's vaccine is 95% effective. These are not just real numbers for us to consider when you're doing these vaccination policies, because you cannot expect 95 people out of 100 will be immune to the infection. The variation is much higher than that 95%. For example, the flu vaccine, its efficacy is between 40 to 60%. Okay, so that's the level of difference that you would generally see in terms of efficiencies of vaccines, right? So one single number, 95% efficient, cannot be used to make these types of vaccination policies, right? So that's the reason why we consider uncertain immunity ratio. So basically, the algorithm does not know ahead of time what is the true immunity ratio that we can achieve with this vaccination, right? Based on that, we run a CRD model, we run an optimization on vaccine allocation, try to solve this problem. You'll see over here that the real immunity ratio is 0.2. This is just for showing. Instead of 95%, let's say 20% is my real vaccine immunity ratio from the vaccine. So I'm just making an assumption. And the algorithm has a way of learning that as you keep progressing with vaccination amounts, and it is looking at the infection counts, number of vaccines given, infection counts and all, and it is making a dynamic decision that, hey, I did not consider the right vaccination immunity value, right? So it changes its vaccination immunity value, that the guess number that it chooses. And as it keeps progressing stepwise, it kind of converges to the true immunity value for that vaccine, right? So that's what we have done over here. In the interest of time, I'll skip some of the other results over here. And so this optimal time varying vaccine allocation mechanism that we have, it can also adapt to multi-vaccine scenarios. So not just a single vaccine that you're allocating different vaccines with different immunity ratios. So this is the 2 vaccine scenario that we have shown over here, that our algorithm can actually match up. So the curved line here is what the algorithm is predicting. This is the immunity ratio. And the dotted black is the true immunity ratio of that vaccine. So we have 2 vaccines with true immunity ratio of 90% and 60%. Okay. And the algorithm does not know ahead of time what is the true immunity ratio. It is trying to learn it dynamically, right? So as you will see, it tries to catch up with what is the true immunity ratio. And the blanket curve basically shows the standard deviation in its learning, because no number is an absolute number. It is showing the standard deviation around. Long story short, our dynamic vaccine allocation can act with what is seen in the real world. We also created a mobile app for social distancing. So for people can sign up for this mobile app. They can enter their epidemic status, whether they are susceptible, infected, or recovered. And based on that, we look up Google Maps and we use some of the Google Android APIs for implementing this mobile app. So if you're walking into a grocery store, what this app can do is it can do real-time sensing of how many other infected people are there in your vicinity. And it is automatically drawing a 6 feet radius around you. Okay, and it is basically giving you kind of your next step, just like you will use Google Maps to go to a destination. Right? It shows you the direction, the path, route planning to go to a destination. So this app is going to be doing exactly the same thing. Looking at the number of infected around you, it will basically show you the right route to go to your destination. Okay, so we created something like this for social distancing. For the hospitalization capacity planning, we have a very elaborate simulation mechanism. There are many components in a hospital. We have patient prioritization, triage room, ICU use room, a ventilator use simulation, hospital bed simulation, ambulatory care simulation. So there are many of these different simulations that have been put together in the VSU Medical Center hospital system. And our epidemiological models were feeding into this elaborate simulation, all right? Based on that, we were making predictions in terms of how many hospital beds and ICU and ventilators would you need and all. So I'll push through very quickly. And the last piece here is in the human part, right? So that's very important. So what we did was we looked at Twitter trends and try to understand public perception towards policies. And the policies that we considered here is social distancing, masks, and vaccination, okay? And this is quite interesting because we looked into real-time data from Twitter between March to December 2020. And to tell us, what are people thinking? Are they thinking positively about social distancing, mask, or vaccine? Or are they thinking negatively? Hey, I don't want to do vaccination because it doesn't work. Right? So that was the goal of this work. This is more of the Twitter data sets, the positive versus negative sentiments. This is for the different United States. You'll see a lot of negative sentiments, blue curves over here and all. So let's look into the main results over here. So we saw that from the world tweets, and the same thing is seen in the US tweets as well, people are more accepting the mask procedure. So the positive sentiment is going up for masks. So more and more people want to follow the mask policy. Vaccine and distancing, social distancing, have been going down. This is until December, by the way, right? December of 2020. So less and less people feel good about social distancing and vaccination. They think that they don't work, okay? But for masking, the positive sentiment is going up. Same trend is seen in the US states as well. For masking, we have a good positive sentiment, but social distancing and vaccination, the trends are falling quite a bit. Another interesting study we did here was how about the red versus blue states in the US. So we know that Republicans may not be, that was kind of like the public perception, that they may not be following the mask, social distancing, vaccination ideas as much as the Democrat states, right? However, we saw that that's not necessarily the truth. It's very even, right? So about 52% positive sentiment towards distancing, mask and vaccination, about 51% positive sentiment for the red states, for the Republican states. So really not a lot of difference in the United States based on political makeup of the different zones. So overall, the key findings here was we saw a reluctance towards vaccination. Until December, people overall were not so positive about getting vaccinated and all, okay? We did see a high use of masks, so people were feeling more and more positive about that. We also saw that high age and ethnicity affect public sentiment in the US. So elderly people and some race, they feel more positive about vaccination and masking and all than the others. Busy airports, actually places which are more cosmopolitan, are more accepting. They have a positive sentiment towards mask, social distancing and all. And very interestingly, states having a large homeless population, okay? So turns out that they have a very strong importance given to mask wearing. Okay, so this also came out from our studies that places having a high homeless population are actually being more positive towards mask wearing. So with that, these are some of the research results that we had for the policy-making part, and we are right at the time points that we have to close out the presentation, and we can now start taking some questions. Thank you.
Thank you so much, Professor Goss. Any question for alguna pregunta para el profesor Pritan?
Yes, I have a couple.
Mm-hmm.
Thank you again, Professor Pritan, for your amazing presentation. I have a couple of questions regarding two things. First, the infrastructure, the academic infrastructure we would need here in the Dominican Republic to create these professionals, these researchers who can actually deal with the data you've been talking about, deal with machine learning, deal with the data mining required. What should we do in order to get there? Like what, let's say, professional paths do we need?
So this is actually a very important question and a very good question. And what I can tell you is, so when we were doing this modeling studies and all, the data sets was the most important thing. None of these models work without good data sets, right? So in Virginia and in pretty much all the other countries, the federal government actually allocated a lot of funds where there were volunteers going out for contact tracing. That's very important. So people who are, so the testing rates were increased a lot, right? So you have seen that in March, April, the testing rates were not so high, but after that, the testing rates have increased a lot. One was public perception that everybody who is feeling some symptoms should get tested, but then the availability of testing kits. So of course, that needs funding from the state and from the federal government to have enough testing kits available, okay? That's what's happening, by the way, in India right now, because not a lot of testing was going on over there and people did not know how much the infection spread. So high testing is critical, right? That's step one. And the second one is contact tracing. So when we were doing all of these model projections and all of that, I can tell you in the state of Virginia, we had a very robust contact tracing system. So people who are getting infected, right? So there were regular phone calls to their homes. They basically had to sign up that the last 7 days, which places did they visit and what types of people did they get in contact with and all, right? So for that, you need volunteers. For that, you need paid people, not just volunteers, paid people who would do these phone calls and actually get you the contact tracing graph, okay? Of course, all of this would need some funding to be able to do it that way. Whether we can do it completely at the country level is looking at the federal government putting in funds for this. But that type of data set is very much needed. In the US, until April, May, our model predictions were completely wrong just because of this problem. We were not doing enough testing and we were not doing proper contact tracing as much. But after that, moving forward, the testing rates increased enormously, and then contact tracing and data governance became very important. So that's how you have to do it. And this is something that the state or the federal government has to put in funds to be able to do. You can run modeling and machine learning only when your data sets are very clean.
Of course. So that would be the first step to get there. And the other question is, what do you prefer in the long term? Learning-based algorithms or differential equation simulations?
So that's a very good question. That is a very good question.
Would you prefer,
okay,
let's say, for this situation?
Yeah, for this situation. And that's a very important question. Now, here's what I think. Towards the beginning of the pandemic, machine learning will not work. We just don't have enough data, right? So in the first phase, the first 6 months of the pandemic, you're better off going with simulation, with SEER models and SIR models. Also, I feel, so there are two ways of looking at it. Even in SIR models, you can make them top heavy. So basically I'm saying that, okay, let me reduce the susceptible number by this much because this is what is happening in this place, right? Social distancing happening, reduce R0 and all. You can bring in so many things into your SEER model. That's what I call top heavy models, right? What we have seen is do not make your models top heavy. Keep it as simple as possible because there are a lot of dynamics that is going on here that you cannot properly measure, right? So keep it to simple SIR, nothing more than that, and fit to the data, right? That gives you the overall rates. After you have done that, you bring in some latent factors. So check out the recommendation engine, the recommendation based framework. So Netflix and all of that. So they basically do matrix factorization and convert it to latent factor. What is the latent factor? It's basically saying that, okay, R0, China says R0 is 5, but we are seeing R0 is 4. Just giving an example. Okay. So if that's the case, there are some latent factors that we don't know. What are they? They are playing a role in reducing this value. Now you bring in post-processing, you bring in what can be these different latent factors. Is it the mobility? How many people are moving into that zone? Is it the airport? So is it the road traffic? Or is it more busy airports playing a role? Is it different race? So maybe infections spread more in this specific race. So is it that? Is it the homeless population? Is it spreading more in the homeless population? These can all be, or a combination. So these can now all be considered as a latent factor. Okay, but you don't want to consider all of this in an SIR model because that makes it very difficult to work with. Right? My SIR model is simple SINR, nothing more than that. But once I've got those rates, I bring in the latent factors to say that, okay, why is this rate so much? And that can be done through normal matrix factorization. Now, that's one of the other works that we have done that I did not cover in this presentation. I can send you that paper, just came out last month, where we have done this latent factor-based analysis, where we are saying that we don't want to overload SIR models altogether. We want to do post-processing. Very simple SIR model will give us overall R0s and all of that. But after we have got that, we know what is the asymptomatic population based on our SIR model. We use the asymptomatic population and now do a matrix factorization based method to figure out latent factors, and this can be extended to any number of latent factors, right? If you are doing matrix factorization with latent factors and all, it can be extended to any number of latent factors. So that's the way, that's a post-processing kind of method. And I feel that, so that is also machine learning, if you think of it, because this is doing kind of that kind of fitting, right? So that's what the matrix factorization is doing. But the idea is keep your SIR models very simple, because that's what you need to fit to the real data sets. So we want to keep it very simple. We want to bring in all of these complexities as a post-processing step from there. Okay.
All right. So the SRI models, the matrix factorization, both of those combined to give the best results in measuring.
That's what we saw. That's what we saw. That's what we saw. That keep a very simple SIR model, but then try to bring in all of these complexities as a post-processing step. And we saw that it worked quite well. Yeah, but this is all after the fact. Yeah, this is all after the fact. So I can send you that paper. It came out in IEEE Transactions in Computational Intelligence in 2021. And I can send that one to you, because that's a very different take at this problem. And the reason we took this route was based on our experience that none of the models were working very well with the kind of uncertainty that we have in the data set.
Thank you so much, Professor Piritan, for accepting our invitation for your important talk here. Thank you for coming to Dominican Republic virtually and for the mini course yesterday. Thank you for all your support to our country.
Thank you, Adrian. And I look forward to seeing you in person very soon.
Yeah, thank you.
Thank you.
Los dejo. ¿Hay alguien del ministerio por acá?
Sí.
Sí, profesor, le dejo la palabra. Muchísimas gracias.
Ya terminamos con el simposio.
¿Sí? Muchísimas gracias a todos los que participaron de esta charla magistral. Continuamos con las planificaciones, con el programa planificado de nuestro Congreso. Pueden entrar a las diferentes salas donde van a estar los temas de interés de cada uno de ustedes. Muchísimas gracias por participar y un abrazo a todos. Thank you, Professor. See you.
Thank you, Professor.
Thank you. Bye.
Buenas tardes, bienvenidos y bienvenidas del Máster en Diplomacia y Relaciones Internacionales de la Escuela Diplomática. Tiene la palabra, en primer lugar, el embajador director de la Escuela Diplomática, don Alberto.
Hola, buenos días.
Buenos días, Letsai. ¿Me escuchan?
Sí.
Estamos esperando que los expositores terminen de entrar a la sala para darle inicio a las presentaciones de hoy. Hoy tenemos que comenzar a las 11:20 de la mañana.
Ok, quería comentar que yo voy a presentar la ponencia del doctor Esteban Prieto.
Ok.
Porque el doctor Esteban Prieto por compromisos previos no puede estar presencialmente, pero él grabó el video de la presentación y yo lo voy a proyectar, ¿sabes?
Ah, perfecto, no hay problema. Muchas gracias.
Y entonces, nada, por aquí estaré.
Gracias.
Gracias a ti.
Buenos días a todos. Vamos a dar inicio con las primeras presentaciones. Les voy a dejar la palabra con el señor Miguel Euclides.
Buenos días a todos. Bienvenidos nuevamente a esta sesión del 16º Congreso de Investigación Científica Internacional, elaborado por la MESIP. Estamos todos muy contentos por la participación de los ponentes que vamos a tener a continuación durante esta sesión. Vamos a empezar la primera presentación con la especialista Jessica Hernández Secades. Jessica, ¿estás ahí?
Jessica, no se escucha.
Jessica.
¿Tiene el...
Ahora sí.
¿Ahora sí?
Sí. Diez y 20 hasta las 10:40, Jessica. Puedes compartir pantalla.
Sí, un momento. Ah, no puedo compartir la pantalla. En Zoom. Ujú. Vale, disculpen la demora. Bueno, la presente investigación fue elaborada en conjunto con el Instituto de Meteorología de Cuba y el Instituto Superior de Tecnología de Ciencias Aplicadas de la Universidad de La Habana. ¿Me escuchan bien?
Sí, te escuchamos bien. Sí,
Sí,
todo
se
bien.
escucha.
Fue un análisis del potencial energético unimotriz en los mares adyacentes a Cuba, elaborado por, bueno, quienes habla la licenciada Jessica Hernández Secades y el doctor Daniel Ayax García Cortés. En la actualidad existe, como todos sabemos, una gran dependencia hacia la generación de energía eléctrica a base de combustibles fósiles, lo que esto resulta ser insostenible desde el punto de vista ambiental. Es por ello que a lo largo de los años, como los océanos siempre han constituido un enorme reservorio de energía en constante movimiento, se han implementado diversas tecnologías para la obtención de energía a partir de las corrientes, las diferencias de gradiente entre la salinidad y las temperaturas del mar, la energía de las mareas, o a partir de la energía de las olas, o mayormente conocida como energía ondimotriz. Cuba no está exenta de estos problemas, agravados además por ser un país del tercer mundo, bloqueado y con una economía dependiente totalmente de las importaciones del crudo. Debido además al precio actual del petróleo y a los lineamientos de la nueva política económica que el país ha llevado a cabo, donde pretende incentivar el desarrollo de fuentes de energías renovables, se presenta entonces la necesidad de obtención de nuevas vías para la producción de energía eléctrica. Por su condición de isla, rodeada de mar, estamos rodeados de mar, sería lamentable desaprovechar tan accesibles recursos como las energías marinas.